Welcome to Blue Collar ICs, the podcast that pulls back the curtain on interventional cardiology. Hosted by Jordy Colada, Bill Dixon, Brian Brown, and Todd Flor, this is where real doctors talk real work. From the Cath lab to complex cases, new devices, and hard-earned lessons, these are the conversations that don't happen in textbooks. No hype, no fluff. Just experience, expertise, and straight talk. Welcome to the conversation. This is Blue Collar ICs.
All right, well, I'm subbing in tonight for an incredible MC, Jordy. He did radio for years and knows how to do it a lot better than I do, but I'm honored tonight to welcome this episode of Blue Collar ICs, where we are featuring Dr. Kenneth or Kenny Rosenfield. He was honored by the TCT with a Lifetime Achievement Award. Incredible. So what an honor to have him on the show tonight.
Congrats.
As always, we have Dr. Bill Dixon. I want to put emphasis on this. He is my co-host. This is not his show that I am also on. We're doing it together. And then also Todd Flor, our resident CEO of CELT Scientific. So first off, I'd like Dr. Rosenfield to introduce himself, tell us a little about yourself, and then we'll get into our day and our topic for tonight.
Well, thank you. This is really a privilege to be on this podcast. I'm honored, and I'm still at work here on
Blue Collar, man.
Man, this is Blue Collar. It's hardcore, and I'm an interventional cardiologist and vascular medicine specialist at Mass General Hospital. I've been doing this longer than I've been alive, actually. So. It feels like it. And, today I had 3 carotid cases and 1 complex coronary case. And, like the other guys on this podcast, we got to go head to toe and do whatever you have to do. That's blue collar, hardcore. And I've been involved in a lot of device development and seen a lot of things, done a lot of things. I've had a pretty blessed life so far, and I hope it continues. So thanks for being on this, for allowing me to be on the show.
We're honored to have you.
Welcome.
Bill, what? Yeah. Oh, you first, Todd.
I've got to mention something that was brought to my attention today.
And this about my personal life, because I don't know that we need to get into that.
No, it's been brought to my attention multiple times, but I had the best answer today, actually, and I haven't known how to respond to the fact that I've had a few people say, hey, man, there's no apostrophe in BCICs because it's, I guess, possessive. And I said, or whatever. Yeah. And, yeah, see, I'm blue collar, man. I went to public school. And that's what I told them. I said, we're blue collar, man. We're not into, like, grammatical perfection or anything like that. I think it's perfect. So, anyway, I hope you guys are I'm
glad you brought that up because a friend of mine said, hey, how is it going with Salis? And I said, it's pronounced Salis. And they said, well, that's not how it's spelled. And I said, what?
It is what it is, man.
It's just like say less. Say less.
Yeah. Anyway.
So, Bill, what were you up to today?
Today, I was doing elective cases in the lab, which is awesome. And I'm not having to cover STEMIs or ER or any of that stuff. So I had a couple of left heart cases. One was I do snuff box, distal left radial for.
Are you kidding me? Are you serious? You do the snuff box?
Dude, I've been doing that since 2018.
Why?
Yeah. I love it.
Why? Just I get it with the left. It's on top left.
That's what I used to
say, guys. What's snuff box? I think based on what Brian said.
So it's the top of the left hand.
I've never heard that before.
It's called the anatomic snuff box. So that's where the old ladies put their snuff.
Yeah.
That's what it's for. So if they've had bypass, you can go femoral and get everything. It's hard to get the lima from the right wrist. You can do it, but it takes more time and contrast and stuff. But the left radial
groin exists, right?
Yeah. I've never had anybody bleed from the groin when I go on the arm. So I go in the wrist the radial artery comes up over the top of the hand. And so going left radial is a pain. But if you just roll their hand over it, put it over their groin, their left groin, it's just like a left femoral case. And I can get all the grafts, and I've done interventions and everything. So I've been doing that. I've probably done hundreds.
So since 2018, how many thumbs have necrosed off people?
Zero.
Good.
All right.
Good.
I had one person that had a bad hematoma, but that was it.
Well, all right. Who turned you on to that in 2018?
Mateen Kudus and Clay Sizemore. I was at a meeting and they both mentioned it. Like, I'm going to try it, and I love it. So I did that. I did a couple of hearts. I did a diagnostic peripheral that's going to get bypass, and I did a complex critical limb ischemia case. A couple of tibials were occluded in the same side, and then the intern Amelia from Salus, who's their social media guru, was there doing some filming today. So one thing I made her do is I made her put lead on and come in the lab, and she was out after about 15 minutes.
G-Liv lead? Regular lead.
No.
Regular lead. Bad back was bothering. It's like, so now you see.
That picture was great of you two. And she texted me. I sent you the text. And
yeah,
she told me that she had an amazingly
yeah, we brought her in the lab.
impactful visit there and learning so much. I'm just, thank you.
So I've got G-Liv lead. Kenny has G-Liv lead. Why were they filming you? Do you have something different?
I'm very photogenic for one thing.
Doubtful.
Were you wearing lead or with
I had G-Lift on.
you had your
Todd wanted her to come to the Mecca. So, so
Arrow shield. That's why she was there.
well, that's true. She was there.
was it with the AeroShield? Were you wearing lead or what?
I was.
Like the heavy lead,
The G-Lift.
the G-Lift, yeah.
But what's your plan, Bill? Shell?
Yeah, Arrow Shell. So my plan, I don't want to give it away, Todd. I don't want to
Yeah, don't do it.
give it.
Yeah.
So lighter lead, even non-lead product, non-apron products maybe that could be worn. So we're getting there. Some states regulate it, but we're getting there. But it's a phenomenal product. Every case in that room, we use the system. So it works great. So let's talk about real quick the 4th. What are you guys doing for the 4th?
Kenny, you're on call. Brian, you're on
No, I'm not on call, and my significant other and I, at her request, are going to what's it called, Canyon Ranch, to get she wants to get massages and have a little retreat. So that's where we're going, and I'm not like that kind of guy, So I did sign up for a couple of deep massages, but all this other frou-frou stuff, I'm not like.
You're blue collar, man.
I'm blue collar. I'm not into the stuff. I am not. I want to catch up on my charts and all the other. Yeah, that's right. Brian, relaxing to me is to get that stuff done.
Oh, it's a good feeling when you're zeroed out, but then it just starts right back the next day.
Yeah, exactly. But it's in Western Massachusetts. It's beautiful out there. I'm gonna take a couple of bike rides, and it'll be nice. Yeah. What are you guys doing?
I honestly have no clue. Tonight is our 4th of July party at our country club, and so my wife and children are there. And after the show, I'm going to go over there and watch the fireworks. But I don't know what we're doing for the weekend.
So I want you guys to feel bad for me because I'm on call Friday, Saturday, Sunday as the only interventional guy. I would be on call Monday as well, but I got jury duty that I can't get out of.
Oh, that's even more charge to get.
How can you not get out of jury duty?
I've been able to get out of it before. So the last time it was like 3 months ago, and I'm like, I got patients and all this. And he's like, all right, well, we're going to move you till July. So you got time to clear your schedule. So, yeah, so 3 days of calling and jury duty.
And Todd, what are you doing?
I'm like Brian. I mean, I'll be in the office tomorrow, and no real. Probably there's a couple parties in my neighborhood on Saturday, just low key, laying low. So I'm good.
It's gonna be pretty hot up here. It's gonna be like 100.
So I love it because everybody says, "Oh, it's so hot in Florida." When I tell them I live there, they're like, "It's hot everywhere in the summer. It's hot in New Jersey.
Boston's like one of
and you guys don't have the AC that we do. We have killer heat.
Point.
It's 60, it's 70 in my house."
So, Kenny, in these carotids, what French size are you using for access?
Okay, so I'm using the big news there is, so two of them were pretty standard carotid. It's actually pretty interesting because this is actually great. All right, so I'm using the NeuroGuard system, the Contigo NeuroGuard system, which is now sold by Medtronic. I'm telling you, it's completely changed. For the past 4 months, it's the only system I'm using. It is unbelievably slick. If you're, not doing any training or anything and don't have a fellow, you just have a, somebody that knows what they're doing assisting, you could probably get through case in 20 minutes, skin to skin. It's very slick, very good. It's a lot. I don't mean to be an advertisement for this thing, but boy, it is really good. And, it's incorporating the balloon and additional embolic protection system that's 40 microns. And these cases, I think I've done like 18 or 20 now, and they've been really good. About half of them I use Shockwave. So I use IVL, and, it's incredibly...
Were you guys in the trial?
No, I'm not in the trial. I told Sukas, what's going on, man? Why am I not in the
I gave him crap too. I don't do carotids, but I have partners that do. So I gave my local rep crap. She has no control over it, but
yes,
they said they want to keep it tight. Understandably.
Yeah, they want to keep it tight. He said the Mass General, takes too long to get things through. And I said, baloney, but meanwhile, I've done like 10 cases in the past 3 months with Shockwave. And it's actually pretty cool. Even though it's not tailored, it's a coronary device. I need a little bit more emitters and so on, but you see the even the heavily calcified just sort of gradually expand, and without a lot of pressure, like 4, 5, 6, 8 atmospheres maybe at the most, and it's less traumatic and less. What I've really noticed with this device, which is not really well described yet, but it has been acknowledged by others as well, is much less of the vasodepressor response from the carotid body.
Really?
And
Less barotrauma.
it's
Wait.
less barotrauma.
Can I ask a question real quick? Sorry.
You gotta raise your hand.
Yeah. As the only person on here that's not a physician, you're talking about using, you said Shockwave, right?
Yes, sir.
In the carotid.
Correct.
Is that off label right now?
I would say yes.
Yeah.
There is a trial that's starting up with it.
But it's done all the time.
It's sparse Shockwave, but I've been using it for a couple of years, and it's actually very nice. It transforms the heavily calcified into yes, you can do them. I don't care. It doesn't really matter to me. Anyway, bottom line is that these 2 cases were really nice. I did not Shockwave them. They didn't need to be. They were both symptomatic. With TMB, actually, transient monocular blindness. And one case ended up having, she came down from New Hampshire, transferred in by a surgeon, and one of the surgeons here, and young guy, and he wanted to do an endarterectomy, but then a cardiology consult showed that this patient had really bad coronary disease, and was having angina. So she went to the lab yesterday, had a 20 cc right coronary intervention, beautiful results. She has moderate left main disease, pretty bad distal LAD disease, but the right was the real problem. And then we had a multidisciplinary team discussion because of her left main disease. A cardiac surgeon was consulted, and we ended up having a heart team meeting for a carotid team. And it's so clear. This is carotid stenting is just so sweet and so nice and easy. Anyway, bottom line is that he was convinced. We got the surgeon to, agree he was sort of shamed into it. He's only done a very small number, 3 or 4 carotid stents. So I invited him over and I let him primary operate the case.
That's awesome.
And I told him, look, Zach, I'm going to get you trained up this year because you're, second year person. We're going to, every time I do a carotid or one of yours or whatever, we'll do it together. And by the end of the year, you're going to be like kick butt carotid stenter because you need to know. This is a great therapy, and the CREST 2 trial showed it. It showed impressive year in, year out reduction in stroke compared to optimal medical therapy alone. And you can't ignore it, even though a lot of people are ignoring it. And patients like it. So this procedure took like an hour because I was training him.
So Brian asked, what size did you use? Sheath.
Okay, you want to get to the size. Okay, 7 French, because this device, you can use it 6 French, but if you use a 7 French shuttle sheath or 7 French, one of the other catheters, then you can actually do pictures through it, and it's a little bit nicer. So 7
Did you
French.
close the groin?
I closed it with a CELT.
All right.
Okay, I'm texting.
Oh, you want to get into closure here, huh?
Before we move on to that real quick, I want to reiterate Kenny's point that this is exactly what we need to do is continue working together, bringing people from other disciplines and saying, hey, you can do this too. The more people doing it, the better. And that's wonderful.
Brian,
Ribo.
I want to say,
I've been trying to do that with limb flow, essentially. Like, let's do all the cases together.
I do detours with the vascular surgeon. We do them together.
Yeah, it's very good. I mean, the 3 of us that are collaborative like that. It's really too. I've been fighting this battle my whole life, but I've also been fighting battles about closure my whole life. You want to get to closure, Brian? So
Were you gonna say something, Todd?
7.
I was just gonna say, Kenny, just listening. I mean, I know all 3 of y'all are great at this, but hearing that story is so cool to hear how you're approaching your vascular surgeon colleague in a way of, we're doing this together. This is best for the patient.
Yep.
And you're going to get trained up instead of a combative. You're all gifted at this, but going about it in a way that you bring people together versus, polarizing specialties that was really cool to hear that story. I agree with Brian. I thought that was really cool.
It's cool. But and then the other thing is we closed the 7 French femoral access site. You can do these things from the radial, but I don't like to. I like to do them from the femoral. And I used a 6 French CELT, and she's sitting up, bolt upright. About 45 minutes later.
So CELT is probably the newest closure device, correct?
Yeah, there may be newer ones that are out there. A couple that
Vascade is a new one coming out.
All right. The Vascade's been around. So
We have Vascade itself. They have a new closure product that's coming out shortly.
okay. So we're going to talk closure. So, and can you correct me if I'm wrong, but closure's been around since the late 1990s. And I think the very first closure device may have been called ProStar, but it was a Perclose system. It had 4 needles, and you had to tie your own knot like around a hemostat. And the first time I saw somebody tie that knot, I was like, that's exactly how I tie my hooks on my fishing line. They're like, yeah, it's the same knot. I guess it's a modified surgeon's knot, but it's also a fisherman's knot. Yes, knot. And then
it's kind of a slip knot.
Yep. Yeah, and then it progressed to, they had this little device that you would the suture through, and it would tie a knot as it was traveling through this little plastic box. And that was before it was already tied in the catheter. But Perclose came out, and Angio-Seal was actually pretty early on as well, because when I was a fellow, Angio-Seal was available. None of the attendings wanted to use it. But those are and I still use Angio-Seal.
No, there was another one that was just collagen. It wasn't Angio-Seal. It was
VasoSeal.
VasoSeal, which was taken off the market.
Yeah. St. Jude bought it and shelved it.
So that came out.
If I remember correctly.
Well. And then Minx is around, and so you have like suture mediated, you have collagen. So Star Close was one, which I actually kind of liked the little Star Close device. It was a little thing that grabbed it. It kind of hurt a little bit to the patient. I didn't feel anything, but I actually like that. I like that. Okay.
Have you ever used that, Brian? Star Close?
No.
It was weird. It had 4 steps, and you had to split the sheath, and you had to make sure you had a good track.
Helped develop that sucker.
Actually,
Really?
I
heard you had to split and dissect, or you would not get the result.
You had to make sure you had a good track.
Right.
But I like the device.
Actually, track. That's exactly right. Or otherwise, you ended up on top outside the vessel, and you didn't get good closure. It's a little circular thing.
Worse. Right?
It's a little circular disc with prongs that you went in, and then as it was nitinol. So as the prongs went in, and then you released it, they would spring up like that, and by doing that, they would bunch up the entry to the artery. That thing, I don't know anybody uses that now anymore. I think.
Yeah, I gave it a shot. I liked it actually. And then Vascade has the current iteration is better. The previous ones had all these different colored bands, and it was too many steps for me to remember and deal with. And Mink's Angio-Seal for me has been so dependable. That's what I've used, but I've never tried CELT. So
Are you serious?
Oh man. Oh man.
we just got OCT. Remember last episode? We just got to go.
You just got OCT.
So I just was asking David how many we've used here. It's probably over 5,000. CELT is, so I'm a femoralist, period. End story. I become a femoralist. I'm not a snuffer. Sorry, buddy. But I learned in femorals, and I did femorals my whole life, but this thing is hands down the best, most reliable closure device that you will find. I mean, there are people, I'm telling you, I saw this thing 5 years ago, 4 years ago, whatever, when David was sitting out, I think it was at Viva, and I came out of one of the talks and saw this guy sitting in this, really good looking guy sitting at a table. I said, "What's this thing?" And he said, "It's CELT." And he showed me, and I said, "Oh my God, where's this thing? Is it approved?" I said, "This is unbelievable. It's like a rivet. It's the most reliable closure device." Here's the thing, Bill. I don't like Angio-Seal because, number one, I've had a lot of failures with Angio-Seal over the years. Number two, I don't like putting collagen in the artery because I like to have access right away if I need to, be able to get access. I like something that's inert, and CELT is inert. It's like a rivet. You put it in, it's brilliant. You go through the sheet that you already have in there, you pull it up, it goes on the back side with like a foot plate, then you put something on the front side, it sandwiches the vessel, and it's done. And it is not going to go anywhere. It's not going to break off. It's not going to, not get a good seal, occasionally. So in all these cases I've done, I don't know, thousands of cases, I might have had, I've had a couple of modest bleeds, nothing like, no big bleeds at all. And it was a little, sometimes you got to hold it for 4 or 5 minutes, just sort of put some compressors on there for 4 or 5 minutes, and then it stops. Occasionally you put in, epi, Lido with epi because of the local stuff. But it forms collagen around the fibrin around the wings, and then it's done. And what's really interesting about this device, and I'm not, look, I love this device, but cardiology community, a lot of everything's sort of gone towards radial, which is fine. But I have so many of my colleagues, we have a lot of complex cases here at MGH, and they run into trouble with radial, and they, it's a loop or whatever it is, and they're struggling there. And I just think it's like, if you just go in, go femoral, why would you? There's no issue. And especially
Bob Elman, he's doing more radial, but he said radial takes a simple case and makes it hard.
Exactly.
That could, and it doesn't mean it will.
I'm a radial guy.
Yeah. You get it.
They haven't talked about manual compression yet, but one of the problems is there's so much radial. There's not good hemostasis experience. People have lost the experience, so I don't.
You mean the like in recovery, Bill?
Yeah.
Dr. Dixon?
They don't know how to do it. Brian, you want to introduce your guest there?
I do. Right before we get into that about manual compression, it's not just the skill set, it's the throughput of the lab. We're at maximum capacity in the holding area. We have only so many beds out there and so many labs, and people need to move through. So turnover is everything. So
yeah,
it's a perfect time to introduce a friend of mine, Dave Gunther. Dave works at the Sorum with CELT, and the first time I met Dave was a cold call. He came to my OBL at the time. He said, yeah, I got this closure device, and I showed it to him, and he said, it's great in calcium. I said, why would it be great in calcium? It's a piece of metal. That's nonsense. He said, no. It conforms to the calcium. It's gold, Jerry. It's gold. So that's how we first met each other. So why don't you introduce yourself, David?
Well, I didn't even know there was a podcast going on. I just heard closure and I like heard it. Yeah. So
That's probably factual.
people start talking about closure and I come out of the curtains like a psychopath and start trying to sell my stuff. No, I'm just kidding. Yeah, no. So thanks for letting me join. Do I sound okay? I just want to make sure.
Yes, they sound great.
And your light's much better than Todd's. So
All right.
Well, the only work on that.
Bill, the only reason why you're not using it yet is it's a pain in the ass to get to Tallahassee. But as soon as I figure out a wormhole to get there,
where do you live? Where do you live?
Yeah.
Where do you? That's a direct flight from Charlotte.
Yeah, I know. There's only like one a day, though. I'm very lazy. I like options.
No. So, well, the Angio-Seal people don't have any trouble getting there.
Yeah.
We don't have Angio-Seal.
That's Terumo now, right?
So yeah, I put in thousands and thousands of
That's how
Angio-Seals.
your runner up is.
One of the downfalls of an Angio-Seal is that foot plate can grab a posterior plaque and pull it up, and you don't know it as you're doing it because you're doing it blind. And then you're sealing the vessel off, and you got to reopen it and use a hawk to cut out the collagen and all this.
So I want a device where the vessel doesn't have to be pristine to use it. That's what I want, because invariably it's the patients without pristine vessels that you really want to close. And it's that 5 o'clock.
So you,
days.
I close every vessel. It doesn't matter what you CELT. You don't have to worry about calcium because it's not dependent on the vessel like puncturing like Perclose, like that. So it works really, really well. I'll just tell you that. Look, our guys, the neuro guys are using it because they like the fact that you can put it in a patient that's fully anticoagulated. And you don't have it'll close those patients that are fully anticoagulated, and they can leave those patients with, stroke symptoms on anticoagulation. And my cardiac surgical colleague who does most ECMO, who does antegrade punctures on the the perfusers in the femoral artery, like halfway down the femoral artery, he uses CELT because you don't have to. It's
Uses CELT for his antegrade closure.
Yeah.
So that's off-label, but I use it exclusively for antegrade sticks, but you have to get a very shallow angle. There's a little bit of a learning curve. Don't come in at 90, bring it down because the device needs that kind of that angle to get in the vessel.
It does, although, I watch it under fluoro as I'm pulling it back, Brian, and
You can always do that.
it pops into the right place. Then I expand it. I mean, there's some art to the antegrade. You're right, but the reality is because it's Chris Qualick, a vascular surgeon, he's sometimes that R2P stuff doesn't work so well. You need to do B2P, brachial to peripheral, and because you can't reach, like you said, you can't reach with you were talking about the laser doesn't reach. So Chris is using the brachial, and he'll close it with a 5 French CELT.
What sizes are there?
5 foot.
That's and snubbing.
You
But
close 8 with
5 will
7.
close. 5 will close a 6. The 6 will close a 7 and an 8, and the 7 will close up to a 9.
So you can use that for the ERP.
Yeah.
That was called.
Yeah, I mean, I'm just look, the guys, everybody in my lab knows me. They just all the fellows, when they rotate with me, they get to learn femoral, and they don't know what you said about closure, about manual compression, Brian. How about just getting access in the femoral artery? I mean,
Yes. Yeah.
Can I say? I want to say something from the commercial side that Dave's going to appreciate. So Dave and I met in 2010 when I started at Access Closure with a lot of great people.
that's like Minx, right?
Minx, yeah. Sorry, yeah. And what's interesting is Cardinal acquired Access Closure in 2014, and during that whole experience I was there was all this. That was when radials were exploding. Terumo was doing their thing and doing a great job, and a lot of Access in the Cath lab was going radial. And what's interesting to me is, and I want to hear Dave's thoughts on this, it's now 2026, and this space has just continued to thrive. Like EP now, ablations are being closed, right? Like and more procedures and different specialties. Dave, I want to hear what you think about that and where you see this space going, because there was a time when we were all worried, like, oh, there's going to be no more femoral arteries stuck. Well, obviously that's not the case at all.
Sure. I think what's happened is the small bore arterial closure market is still growing slightly. It's not exponentially growing with the aging population like other procedures, but it's still growing because every single procedure that gets replaced with a radial access, like most of the interventional cardiology and a little bit of the neuro, a little bit of the peripheral, is getting replaced by more procedures that are being done percutaneously. So, great example is musculoskeletal embolization procedures like genicular artery embolizations or prostate artery embolizations. So what's happened is if you're a closure device rep, you used to go to the Cath lab and get all the diagnostic and interventional cardiology work. Now it's just there's more procedures just spread out over more departments. So you go to neuro, you go to IR, you go to OBLs. It's so the business is still there and it's still growing. It's just more spread out. Does that make sense?
That's really interesting. Yeah, absolutely. Because GAE is exploding, right? I mean,
Yeah.
as a procedure, and Brian,
That-
no.
Well,
No,
I think it's what
of course it is, but there's still a debate about femoral access and that, antegrade access and that, pedal access and that. So if it's pedal access, you're not going to use closure. If it's femoral up and over, you will, or antegrade. But
Yeah.
no, you're right.
But I think it's Brian. It's what you were saying before about throughput. That beds are tight. If you can get somebody home now, same day, with a good, reliable closure device, then or if you are an OBL or an ASC, it can make or break you. As long as the device itself is not too expensive, but time is money. And
Yeah, I'd say probably 80-90% of peripherals are femoral still.
Wow.
I was joking about the thing not reaching. It would have reached fine. I just didn't use it. The IVUS,
But
but
truth comes out.
yeah. So I don't.
So you didn't know if you're a true lumen or false lumen. You just lasered it. Didn't matter. You put an it was true one.
Who cares? I knew.
or eventually you get into true lumen if you lays hard enough.
That's right. That's right.
Well, I knew I was in true lumen. But this lady was interesting. She's 52. Hemoglobin A1C is 14. She came in with blood pressure 200s.
Nope.
And her arteries, her femoral artery looked pristine on ultrasound. It was hard as a rock. I don't think it was calcified. It was just like tough. And I had just a supported wire to get this, and it was ridiculous. It was just crazy. It looked so good on ultrasound, but there was some pathology going on with this lady.
You guys never had access before?
No, but it's what it felt like. It felt like it'd been accessed like 5 times. That's what it felt like. Yeah.
Use a nitrix. Love the nitrix. That's like a go-to to put stuff in over things like
I
that.
used to glide wire 035 glide wire advantage.
I'm talking about something stiff to get access. That's what I'm saying. Super
right.
stiff.
That's right. That's
All right. So active versus passive closure. Dave Gunther, go. Is that a terrible, Brian? You don't like it?
I feel like it's an academic point. I feel like it's a marketing point, but Dave, go on.
I like suture mediated versus other. I like that distinction.
What do you think, Dave?
Oh, I mean, I think the definition of active versus passive is something that Todd, you and I kind of worked with being at Minx, and then me going to CELT. Active closure devices attached in some way to the vessel, whether with its suture or some kind of sandwiching mechanism. Passive, it sits on top of the hole, and like the tissue itself kind of passively holds against the hole. And from a efficacy perspective, basically passive equals works okay in diagnostics and works okay as long as the patient doesn't break any protocols after they go home. Active works effectively in interventions, and it's a lot more resilient if the patient does stupid things, like
Which they don't ever do, right, guys?
yeah, no, they always follow their discharge instructions. Absolutely, yeah. I think with this device, and I don't want to sell too much because this is your guys' meeting, and I don't want to sound biased, but this is the only thing I've ever seen where patients can be particularly stupid and it doesn't seem to bleed at all. I guess the best people to ask is Ken and Brian, as you put thousands in each. Like, have you ever had someone call you for a late bleed like you would in the past?
No. I mean, there have been some modest hematomas, but very few. And you're right. I listen, when I first brought it in here, I said, get the patient up 30 minutes later. get them walking around. And people will look at me like my eyes, they're like, what? You can't do that. Yes, you can. Yes, you can. And in fact, I want you to do that. Actually, the most fun thing is on the table when you tell a patient, okay, bend your leg up now as much as you can. I love
belly cough.
And everybody, the nurses go, oh my God. Now they're fun, like I actually actively had the patient bend their leg, and I actually flex it up myself because I actually think it actually helps the device sort of settle in. So anyway, it's just like all the negatives, because you're always worried about dislodging the closure device that you put in there or opening things up, and this thing just doesn't do that. The other thing that's pretty interesting about is, so I was saying the cardiology world, when you talk to them, they say, oh, well, I don't want to put a piece of, metal in the artery, or, put a piece of metal, stainless steel. And the point is that, I say, well, what do you mean? We put stents in, number one. Our surgeons put clips all over the place. Why would you know?
I'd give you $100 if you could hit that same spot intentionally in 20 tries. Right?
That just doesn't happen, right?
Well,
Dixon?
Dave made the point to me, a vessel is not, this is the only access spot, right? It's here, it's here, it's here,
Yeah.
it's here, it's here, it's here, it's here, it's here, it's here.
No, I always tell patients I'm going to go in the exact same hole that I went last time.
Well, actually, it's funny you say it because I use the thing as a fiducial. It actually gives me, it's like a GPS. It tells me
Target.
I look at the
That's actually interesting. I've never heard that.
Oh no, you look at the femoral, you look at the angiogram you took of the iliofemoral angiogram of where you got access and the previous time, and that's exactly where your CELT is, and you say, I was a little low last time, I want to go a little higher, or I want to go right next to the CELT, and frankly you can either do it under fluoro, not even ultrasound, or you can do it under ultrasound because you see it both ways.
So I just watched the video of deployment on the website. It's strikingly similar to star close in that you have to get 90 degrees and pull on it and push a little bit. It kind of looks like that a little bit to me. Not quite the same, but there was plaque in the video in the vessel that was being closed. So I kind of like that. So I wish
She'll say if there's a lot of posterior plaque, you need to be using ultrasound at the beginning, picking your spot so that you're not dragging the discs against the posterior plaque, or you're deploying it under ultrasounds that you see where the discs are at before you pull up. Now, I'm kind of lazy, so I love fluoro at just using that, but that's because I'm confident with my access site.
so. I would like some company to figure out. So let's say you do your groin shot at the end, right? I typically do it at the end. I trust my ultrasound as far as access. So you go your 30 ipsilateral, but then you move it back to AP. I would love for an imaging company to figure out how to overlay your 30 RAO on your AP so that you don't have to use ultrasound and you can just kind of see, you know what I'm saying? You know what I'm talking about?
No.
I'm trying, but I'm the least.
I feel like you have a point. My problem is I
think it's a great idea. I can't
Be careful about sharing too many ideas on it.
can't verbalize it very well.
Well, it's okay. It's a problem, you have when you're down in south of the Mason-Dixon line. Whatever, down to Tallahassee.
We just got Wi-Fi. Yeah.
Well, the other thing is that the newer devices, the CELTs have it has a blood flow thing. So when you're up against the wall. But you're right. I mean, Brian, you got to watch a little bit with a diseased posterior plaque vessel. We got to watch that a little bit. And
All right. So tell me,
there's some art.
what do you do? How do you manage that, Brian?
If you were to get access where you're concerned that the disc may be dragging on posterior plaque, then you need to use ultrasound and see where the device is at. And once you're pulling up, deploy the disc once you're above it, as opposed to 3 feet down the vessel and you're just dragging.
Got it. Okay.
The blood return thing helps with that because I'm not deploying mine until it's pretty close to the arteriotomy nowadays.
And you do that under ultrasound?
No, I do mine under floor. I'm lazy too. I do it under floor. You go. You don't do it the ipsilateral fluoro. You put a contralateral fluoro. So you go about 45 or 50 degrees contralateral, cone in really tight. You see your arteriotomy and you just pull it back. Actually, what my fellows taught me this, you do it on with a smart mask. Get a picture, put it on.
Well, that's kind of what I was saying. That was the point I was making is you take your picture, but then if you can move your camera back to AP, but that's what I was talking about. Some image that you can use to help guide that. That's
Well, you can't, once you have your smart mask, you can't move it.
That's right.
But it's really very slick. I'm telling you, this thing goes in about 10 seconds. Okay. 10 seconds to deploy.
All right, we haven't talked about Perclose. Let's talk about Perclose.
Perclose is great too. I use a lot of Perclose.
Yep.
Perclose and Perclose. For large bore access, I'm Perclosing things, 2 or 3 of them. And it works pretty well. I mean, it's always though. It fails a lot, but it's very helpful.
It fails though, right? It's on the table.
Yeah. So you may have, Kenny, grandfathered out of some of this board stuff we have to do, this freaking mock and all this stuff. But Brian, do you do the 30 questions every quarter for interventional for your board certification?
I thought I made it pretty clear that I'm lazy, so the answer to that is absolutely not.
Well, how do you keep your interventional board certification? You take a test every year? Oh, geez.
I'm in my 9th year after graduation.
Well, anyway, the point is I had to take my questions by June 30th, so I didn't wait till the last minute. I did on the 29th. And one of the questions had to do with a failed closure device. And it was the question was like, which of the following is most associated with a failure of hemostasis? And it was like the suture mediated, i.e. Perclose, failure rate is like 6%. At least that's what the question said. And the other types of devices were much less.
Vascade? Are you kidding me?
The thing I don't like about Vascade is you deploy it in the collagen and then you pull it out and you create a hole in the center of what you just deployed. You know what I'm saying? Like a donut, and you pull that catheter out. I guess they think it fills in. I don't know. Vascade, I've not been satisfied with. I've tried some.
It's not mechanical. So it's what Dave's saying. It's just it's chemical. And it counts on the chemical, reaction, which I don't like, actually, to be honest with you. It's the EP guys. The reason Vascade made it is because of EP.
Now that's ridiculous. And they'll put in 2 Vascades for venous closure.
Like sticks, right?
How much does that cost? I use a figure of 8 stitch. I'll put in a 24 French for angiovac or whatever, or I'll do a PFA closure.
Pronounced Inari flow treatment.
What did I say? No, it's a different company. Same. All right, maybe I'm doing Inari.
Oh,
So I'm doing something big, but I use a figure of 8 stitch. Now I do spend $200 on the Inari Flostasis. I actually like that little device. But I'm like, I'm not spending $1,200 to close a vein. That's ridiculous.
Yeah,
so that's drink the Kool-Aid.
And you're piling in the collagen. It's just the EP guys. I mean, they got some EP guys that really fell in love with it. And
I showed them how to do a figure of 8 stitch years ago, but
yeah,
they're too app stuff. It's very confusing. That uses all their brain power.
Well, the reason is Bill, is because they can put the Vascade in, they can walk away, and they don't have to come back to it.
Well, somebody else has the whole pressure for 20 minutes.
Yeah, that's right. The figure of 8,
But figure of 8 stitch works the same way.
Figure of 8, but somebody's got to clip the thing, a few hours later.
I just write the order. Our nurses will put it.
This is not the point of the show, but I don't think there should be questions on our boards about specific different company.
Dude, I showed you. I posted the one on LinkedIn. One of the questions was, now this may apply to you, Kenny, does not apply to me or Brian. You are doing a case with an interventional fellow, and he has chosen a JL guide and it's not working. What do you do next? And I'm like, I don't even have fellows. This question doesn't apply to me. That was one of the questions. So this round was.
It's clear the answer to that is fire the fellow.
That's what I said. That was the option, was to get another fellow. The questions are really bad this time. more so than usual.
What was this? Was this the MOC?
It's the longitudinal knowledge assessment where I have to take 30 questions every quarter and you have to score so high, but they don't tell you your score for like the first 2 years or something. It's like a 5-year, it's $1,000. Thank you, sir. May I have another kind of thing. That's exactly what it is.
Artie, I do the one that's once a year.
Well, I do that for general cardiology. Kenny, do you still keep general cardiology boards?
No, I'll grandfather out of that puppy. I'm an old dog.
See, I'm thinking about letting that go and just do interventional.
Yeah, join NBPAS.
Hey,
I am, but our hospital doesn't recognize it.
ooh,
That's gonna change.
A couple of a neurologist tried to get and I was on the credentials committee, so this is way off topic, but that'll get there. I think that'll get there
Eventually, they're just it's thievery is what it is. What's going on?
Yeah, it's larceny. Maybe that's a good word. It's extortion.
Extortionate. See it.
All right, Todd. Todd asked about radial closure. You mentioned brachial closure. What about axillary? What do you guys think about that?
that's so uncommon. I mean, you're probably gonna do balloon closure.
No, people on Winton are constantly doing axillary, Perclose, and putting in 5.5s to do osteoleptmy.
So that probably means they're doing it like 10 times a day, right?
Yeah, it's show off basically.
That's right.
Oh, but honestly, probably pre-close those. That's what I would do for the axillary. It's like pre-close them.
Yeah, Todd, the radial bands are all very good.
I mean, does TR just own it? Is there any like?
No, there's all these other brands. They're all the same. All those little
Right.
brands. They all.
Brian, are you sitting down?
Currently, yes.
You're sitting down. There is a dedicated band for snuff box made by
I
Merritt.
was just gonna ask.
Really?
Just that's 2 straps. The strap.
It's not like you're at 3 thing. It's like a 3 thing. Yeah.
That's cool.
It's like the one for the ankle. So I was actually thinking of a device for tibial access. And all I was thinking is it's not because it's hard to compress and get hemostasis. I want the vessel open and I don't want to have to go up and over and balloon my access site. We need a device that's like a T that just goes inside, lifts your access site up, and then put the compressive band on. You know what I mean? So you know that it's patent. Does anybody else worry about? I mean, I do a ton of pedal access, so I worry sometimes about patency.
For tibials, some people will modify the TR band, but our tech.
It's just compressional. I'm talking about lifting the wall up on both sides. Why? So that it's patent.
I think it's patent.
Yes. Sometimes it's not.
Anybody use FemStop? I use FemStop.
Yeah, I mean, I use FemStop sometimes.
It's a great device.
Only if there's
Hey,
only for rescue. It's for rescue.
Yeah.
when I was in St. Jude Medical, if somebody was out of FemStop, like a cath lab, they would panic. We got those calls. I mean, it was amazing to me.
I think it's a good device if used correctly.
Have it, right?
I feel like if you need a FemStop, you should probably get access and close it with a balloon on the inside of the vessel.
Well, that's so that's another great point, Brian. I mean, I think that's the only problem about that is you got to get access on the other side.
Right. So you're going to put a hole in the other place.
Tibial or pedal. I do that for structural all the time. They call me in there because something's gone wrong for TAVR. I just get tibial access, go up and fix it.
Yeah.
And
But I think
how much
so.
load you put up through the tibial?
I mean, it's common femoral, so it's 6 or 7 in the common femoral. I mean, it fits through a 6 slender sheath easily.
It's like radial.
Yeah.
So we haven't talked much about manual compression. So correct me if I'm wrong, but I don't think there's any trial that's ever shown closure has better, quote, outcomes or less complications than manual compression, but you ambulate people faster, which is a real thing. And you got people that can't lay flat, and it's a real thing. So I'm not doing it for convenience. I'm partly doing it because I don't trust the people in recovery. The worst thing I hate is to do a peripheral and I'm done at 5 and they're anticoagulated and I can't close it for whatever reason. I get the call at 8 o'clock. We've been holding for 2 hours. My God, it's miserable. And manual compression is a lost art. They don't know how to do it. When I was at Duke, we had 3 guys and their only job was to pull sheaths. And we put the patient's name in their room and what time the sheath needed to come out. And they were phenomenal. But nobody knows how to do it. When they get a hematoma, they don't know how to manage it. I went in a room and a resident had put ice on the guy's groin. I'm like, saw that.
He was keeping it cool.
The nurse called me, said, this patient had an EP procedure today, and they're having a lot of pain and swelling in their groin. And I said, you mean they have a hematoma? Like, well, I guess. Is anybody holding pressure? No, they told me to call you. So I think it's becoming a lost art. And in our recovery area, it's people applying to med school who were looking for a job for a year. And you have to be, I teach them how to do it. And I say that's as an important part of the procedure as blowing up the balloon in the artery. Because you can have the best case in the world, but if you screw up hemostasis, I mean, worst case scenario, somebody could die from it.
I remember, Dave, you'll appreciate this. When I interviewed at Makes with Steve McKinnon, he told me in the interview, he goes, this is a tough job because the best you can do is get to par. At the end, the best you can do is close the vessel, right? And there's a lot of things that can happen along the way too. So it's interesting. It's like being the kicker, for a football team or something.
No, the long snapper.
The long snapper. We talked about that recently.
The long snapper. Nobody says, hey, that was an awesome snap.
Yeah, but that's where I think CELT could be good for one of the big medical device companies is you can do better than par because this rep could teach the physician how to get ultrasound guided access, how to be confident in closure, and that's actually adding to the case. So I've
right. So where do you not use CELT? What situations would you not use it?
If it's a large bore access.
Right. I get that. It's not big enough for that, but what else?
Severely diseased common femoral with a ton of calcium everywhere where the vessel's actually narrowed and I had to, still get access there anyways because that's what it is. Then it probably wouldn't.
If it's, I would say that's probably the only one when the actual, not the severely diseased. I don't mind the severely diseased, but if the vessel caliber, the narrow, if it's a 3 millimeter vessel, not use CELT.
All right. So as long as it's big enough, the calcium doesn't bother you, the plaque doesn't bother you.
Actually, I love CELT. Love the CELT. CELT love the CELT. But anyway,
good to know.
There's other. So there's other stuff to talk about. You're right about manual compression. There's never been a study that showed that there's less, favorable outcomes. But I have to tell you, I kind of disagree with that. I think that all the studies that were done, they were done in a study environment. So everybody was really focused on good manual compression. But nowadays, it's not unusual to have somebody have a hematoma up on the floor.
It's incredibly common, or nobody told you, and the patient comes back and follow up, and their butt's all blue. And I'm actually going to send y'all a picture a patient sent me in the office while we're talking here.
I've already seen it, and it's TMI. So
oh, it's good. It's good. You'll have to forward it to Dave.
So at our hospital, we actually pull all the Impellas manual, and we've had Amir Kaki here and talked about the way that he does it.
And you just hold pressure?
Every single Impella.
That's where I'd use a fem stop.
No, I pull it out. I hold pressure for about the first 5 to 10. Then the nurse comes and I have her hold pressure or him, and I show them exactly what to do. Then I watch them, and then I make sure there's a pulse downstream, so not pushing too hard. And then they hold for 45 to 50 minutes, and then we're done. I mean,
so I use a fem stop because I don't trust anybody else not to screw it up. And I go back every 30, 45 minutes in between cases and keep lowering the pressure. And I've had really good success. As long as they have a pulse to start with. And
so with our Impellas, we do it. I'll do it I'll take them out at the bedside with a Perclose that you can get access, put a wire up, with the side port there.
You got somebody hold pressure so it's not bleeding. Is that what you do?
Well, and hold it while the wire's in, and then put the Percloses in. I'll pre-close. I'll Perclose, even not pre-close. I'll even
post-close.
That's right.
And you can, that foot's big enough to get purchase on that hole.
No, what happens? You got to actually you compress the artery down and you pull it up against it, and then it's by compressing. You're actually compressing the hole. You're making the hole like compressed like that.
Yeah.
Got it. And then it will grab. Now, about 1 out of 4 won't grab, so you just do it again with another one and twist it a different way. and it will grab and it will hold. It works pretty well. I'll do it at the bedside. Most of my colleagues want to bring them back here to the lab to close them. I'll do them at the bedside. The other thing is manual closure. Manual closure. So I love what you said about, Brian, what you said about manual closure, about how you do it is so important. It's an art to manual closure.
It absolutely is.
And, I try to draw pictures for my fellows. I should have published these, because it's sort of like, you want the where manual closure doesn't work is if you occlude the artery, and then you get this big clump of platelets. It stops bleeding, but there's a big clump like cephalad to where you held, and then you send the patient back to the floor, and then about an hour later the patient moves a little, and that big clump breaks off and goes downstream. So what you really want to do is hold just enough to get hemostasis, and then you want the platelets to stick to the wall in a linear fashion. You don't want them to be clumped. You want them to be linearly distributed along the arteriotomy, and that is the way you get good closure.
Yeah, I call it patent hemostasis.
Did you come up with
Did I made it up?
What'd you call it?
Patent hemostasis. So all you have to do is have enough pressure that the blood goes down the artery instead of out the hole, and that gets you. No, I'm serious. That's exactly what he's talking about.
That's right. And then you get very good linear distribution of the platelets and the fibrin, and that's what is the stronger thing that's going to hold it. Anyway,
Dumb question here. When you're holding, like, what size is an impella, Brian?
14 French.
All right. So you're holding a groin with a hole that's 14 French to get patent hemostasis. I've never held a groin, and I'm okay with that because it's a glamorous job. I'm curious to know, like, how can you feel patent hemostasis versus occlusive hemostasis?
They have a distal pulse.
So you're just checking the distal pulses to make sure. Okay, all right.
We have a little
different.
What do you see?
Different way of doing it too. I mean, I actually do it. I don't know. It's too long to talk about here, but I find the pulse with my finger, and then I'll put a wad of 4x4s on top, and then I'll hold with my fist here with my this one's feeling the pulse. Then there's the wad of 4x4s. Then there's this, and I can actually the pressure's coming from this one. I'm putting my body into it, and as you lean back a little bit, you take a little bit of pressure off. You can actually feel the blood.
With your left hand.
Or with your left fingers.
Yeah, that's
feel the blood coursing through. Of course, over the years doing that, what's happened is
you've held a few groin. Notice this finger.
This finger, the joint's pretty good there on the right side, but the left ones I use for that. Look at what I've done it over the years by doing.
The other thing was, they'll get a hematoma.
Another
little hematoma, and
we need a Salus for this. We need a G lift.
They'll call you because they got a hematoma to go in, and you get a mound of clot sitting there, and they're holding light pressure on the clot. But that's how you get pseudoaneurysms, because you got this clot and there's blood that's excavating the underside of it. So you got to take your fist and you got to smash it out. It's got to be completely soft.
Totally
hurts, and it hurts.
Yeah,
but you got to do that. You got to make that flatten out until it's soft again, or else they'll get a pseudoaneurysm.
You can make it a little bit easier if you take a wad of the 4x4s and put it under there and just use that, and it's a little bit easier on the patient and you. But totally agree with that, Bill.
There's a cardiologist in the Midwest, and I won't mention his name. You guys might know him, but he has a finger that bends. It's broken. It goes across the top of his hand. And I always wondered, like, what the hell is he holding to make his finger turn into that? Now you know. But he's a pretty famous guy, and I don't want to throw him under the bus, but he's got a pretty messed up looking finger.
Yeah. So as a fellow, I had to pull all my own sheaths, and so we got very good at it. And the interventional sheaths back then were 8 French for a while.
Where did you train? Where were you at Duke?
In the military in San Antonio.
Oh, that's great. Good for you. Thank you for that, by the way.
Yeah. All right, let's wrap up.
It's good. It's all good.
Well, I can tell you.
Wrap up, or is there something you want me to say?
It was a pause.
And you want to close?
Yeah, we're gonna close the closure. What's the take-home points?
That it doesn't matter what studies currently exist. Anecdotally, different closure devices have different strengths, but CELT works pretty darn awesome. And you can't tell me that manual pressure is the same as a CELT. That's insane.
So, Todd, you see there's complete consensus on how we do things as far as closure. And so I'm sure, Dave, somebody's come by and showed it to us. I know I've seen it at meetings, but I'd like to take another look at it.
Yeah.
No
problem.
And do some cases.
Yeah, we love that.
Yeah, I think, and the other message is, obviously the data are fairly compelling about. By the way, if you answer that board exam, don't say CELT because what they'll ask is, what's the preferred axis, and they'll say radial. And I will tell you that I haven't done a radial in 3 weeks. I mean, and I do a lot of coronary work, so
Yeah.
So I don't think, it's not like it's not one or another. It's like individualized for every patient. But overall, radial is what is, guys like Sunil Rao really pushed the radial, technique and with good reason. It's good close.
But the sickest patients, you're femoral, so.
Yeah.
And the last thing you need for a sick patient is a bleeding complication. So.
Yeah, or not to get in a STEMI and not be able to get in, and then you got to convert from radial. I'd love to count the number of radial conversions to femoral. That's a fair number in my lab. Anyway, but it's all good.
Well, this was great, and we're really honored and happy that you came on the show, Kenny. This is fantastic. Dave, thanks for being on. Thanks for sponsoring our episode. Todd, Bill, this is wonderful.
You've been listening to Blue Collar ICs, real conversations from the front lines of interventional cardiology. Special thanks to hosts Jordy Colada, Bill Dixon, Brian Brown, and Todd Flor for sharing their insight, experience, and perspective. If you enjoyed this episode, subscribe, rate, and share the show. Join us next time for more real-world cardiology, only on Blue Collar ICs. Blue Collar ICs is a production of the RealWorks Media Network, Tallahassee, Florida,